What we're going to talk about today is really the evaluation and management of coronary disease in general. I'm going to touch on a few specifics around invasive cardiology, but really this is a talk about what do you do once you figure out the patient's got the disease? In other words, secondary prevention. How do you approach that patient? What's the appropriate medical treatment for that patient? And I think I just was on the web here a minute ago, and there's an article on the front page of the USA Today, the other very definitive publication in this country, that is now showing that the utilization of angioplasty, I'm sure they're talking about stents, has dropped and it continues to drop in this country. And I think it brings up a very important point. I think a lot of this has a lot of lay press around drug-eluting stents and thrombosis and overutilization of the technology and all these things you've seen in the newspapers recently. But I don't think that's the whole story. I think it's medical therapy. I think medical therapy is having a profound impact on these patients. And as Bill has pointed out, the holy grail is to figure out who has the disease before they have an event. Because if they have an event, then they've had something happen, a myocardial infarction, an NSTEMI or something like that. So if we can figure out who's got the disease and get them on medical therapy, we can probably change the natural history of the disease. And I think that's what you're really seeing. You've seen a drop-off in bypass surgery. We've had a little bit to do with that. And you're now seeing a drop-off in intervention, which I think is partly due to some of these other things, but I think it's really due to the widespread use of statins, aspirin, and all the things we'll talk about here in just a moment. So with that in mind, we'll go ahead and get started here. You all know this is a common killer, although it's important to remember, and this is heart disease here, stroke, and other cardiovascular disease. So in all ages, most common cause of death in this country, and most industrialized countries, that's the case. But it's been dropping. It's been dropping in the last several years. And again, I think it goes back to the medical treatment of this disease, these disease states, including hypertension and the other risk factors for the disease. Bill showed a slide, I think, similar to this. This is sort of the pathophysiology of the disease. This is not something that starts when you're 50 years old. It actually starts when you're much younger than that. And if you start looking at autopsy series, it's actually in children where this starts, where you start seeing fatty streaks and the changes that ultimately go along here and progress to this unstable plaque where you get actually plaque rupture, which is shown actually in this slide here, a pathology specimen obviously where you have this lipid-rich core and you've got a rupture of the thin plaque here and then thrombosis. And again, depending on whether this is completely occluding or partially occluding, you either get perhaps an NSTEMI, unstable coronary syndrome, or an acute STEMI, or an acute myocardial infarction. So the degree of this really has an impact on the presentation of the patient. And this is what we're trying to stop from happening. And this sort of shows it in a cartoon way that you get this plaque rupture here, you get some platelet activation, aggregation, you can go down this direction, which becomes non-occlusive. This is how the plaque gets worse over a long period of time. And prior to about 10 or 15 years ago, we thought that this lower pathology here, where you have this buildup of the plaque, you get angina. We thought that's what was resulting in acute myocardial infarction. And as Bill pointed out, it's really not that plaque that gets people into trouble. It's the unstable or vulnerable plaque that he pointed out, the one that's 40 or 50% that causes these acute events because they're lipid-rich, a lot of inflammatory processes going on in that vessel. That's the one that ruptures. That's the one that causes the unstable coronary syndrome, either again producing either unstable angina, NSTEMI, or STEMI. So the pathophysiology has been much better worked out, and so our drug therapy of this is much more straightforward as well. So I'm going to diverge here a little bit. As I said, I want to talk mostly about secondary prevention, but I want to talk a little bit about primary prevention because you guys are seeing both those patient populations in your practice. I see a little bit of that. Most of mine, again, is secondary prevention. These patients have already had an event, and so I get to take care of them after that. But as you know, this is a big problem. The risk factors for cardiovascular disease are shown on this slide, and this ranges all the way from about 20 million people that have diabetes, depending on your definition of what diabetes actually is, what the glucose is, up to people who are physically inactive or overweight or dyslipidemic, in the hundreds of millions of patients who have these risk factors. And so there's a lot of people out there that are at risk for cardiovascular disease. And this also shows the number of traditional risk factors in patients with coronary disease. And two things from this slide. Most people, about 80 to 85% of patients, and that's debated a little bit in the literature, but a lot of patients have the classic risk factors, but not all of them do. And you'll have that patient in your practice, I'm sure, that has no risk factors and they're in the emergency room having a heart attack. It happens from time to time and they want to know why that happens. Well, that's because the risk factors don't completely explain all the risk, obviously. There are other things going on here. But about 15% of people in the light blue here don't have any traditional risk factors. And that's the group of patients that are really difficult to figure out. And perhaps CT or other technologies, other markers will help us with that in the future. Well, chide ourselves a little bit. I don't like these slides very much because I'm a physician like you are, or a care provider like you are. And this sort of suggests that we don't do a very good job of taking care of patients. Now, there's some holes in this literature, but I think it's fair to say that there are a lot of patients out there who either not aware of their hypertension here, about 30% of patients, about 40% have hypertension in this particular slide and are not treated, and only about 30% in this particular analysis were actually adequately controlled. Again, defined as a blood pressure less than 140/90 or less than 130/80 with diabetes. So we've got a little ways to go here with respect to treatment of the disease. This is another slide looking at this treatment gap with lipid-lowering agents or statins or other drugs. And what this points out in these patients, it's a little bit of a confusing slide here, but you've got these high and very high risk patients, and then you've got these high levels of LDL. And the pink group here are the patients in which there needs to be change in their management, but because they're not at target. And so we need to be very aggressive. I see patients from time to time, and some patients are very difficult to treat, don't get me wrong, but I see people on 10 milligrams of atorvastatin, and their LDL is 130, and they've got a myocardial infarction. That's not where it needs to be. You put them on statins, that's wonderful, but don't stop there. The target is less than 100. If they're very high risk, I would suggest less than 70, which we'll talk about in just a moment. So there's a gap here as well. What about diabetes? Again, if you look over here on the far side of this slide, control of all three of these risk factors, total cholesterol less than 200, blood pressure less than 130/80, or hemoglobin A1C of less than 7%. Less than 10% of the patients in this particular trial met all three of those goals. So again, a long way to go with the treatment of our diabetic patients. As most of you are aware, diabetes is now considered as a risk factor consistent with coronary disease. In other words, all your diabetic patients should be presumed to have coronary disease and be treated as though they've had symptomatic coronary disease. So your diabetic patient should be on a statin and other things we'll talk about in just a moment with these kind of targets. Now, we've talked several times about the Framingham risk score here, and Wayne and others have looked at other types of risk scores. This is the classic Framingham risk. This is very complicated. You can go online and plug all the numbers in. You can go to our website and plug the numbers in. The patients can plug numbers in and get this information. But really what you need to understand is it's multifactorial, and you get a total score. This is for men. So you're looking at the age, the total cholesterol, the HDL, systolic blood pressure, smoking status. You sum all that up and you come up with a risk, which is a little hard to read. Well, you can read it pretty well on the slide here. Sort of low is 0 to 10%. This is 10-year risk now. How many of you have patients that you'd like to see live longer than 10 years and not have a cardiovascular event? Part of the problem with this risk factor is you sit down with your patient and they ask you, well, what's my risk of having an event? And you can say, well, at 10 years, it's about this. And again, this is population-based, so it's not perfect for the individual patient. If they're 10 to 20, that's sort of the intermediate risk, but there are some people in that intermediate risk by Framingham risk that when you look at other risk factors, they're at higher risk, and that's one of the things you see commonly in your practice in trying to figure out who should be aggressively treated. And then the people more than 20% risk are considered to be high risk, the ones who need to be treated most aggressively. This is for men. It's slightly different. It's the same technique for women. The numbers are slightly different because women at any particular age have a less incidence. Overall, the incidence is very similar, but at each individual age, a little less likely to have the disease. So this is what I talked about a minute ago. You have this Framingham risk here, less than 10%. That's usually with 0 to 1 risk factors when you look at the risk factors. Then you have this large group of patients that are this intermediate risk by Framingham, 10 to 20%. They typically have greater than or equal to 2 risk factors, but some of those people are actually low risk if you look at other variables, and some of those patients should actually be over here in the high risk, sort of where you would get greater than 20% risk, either patients who have known coronary disease or, as I mentioned a moment ago, diabetes, and don't forget peripheral arterial disease. That's also a marker, obviously, for coronary disease as well. So if you have a patient with peripheral arterial disease, TIAs or whatever, a claudication, they should be treated as though they have coronary disease as well, aggressively. Obviously. So is there perhaps a better way of looking at this? Because the other problem is that this is looking at about 200 patients. who were risk stratified. And if you look here, these patients subsequently had an event over a 3-year follow-up period of time, and most of them had only low risk by the Framingham risk model. And this is what I mentioned a moment ago. You'll have patients come in who don't have a lot of risk, who have events. And so can we do a slightly better job of this when we're trying to talk to patients? And some of this has already been mentioned. These are some things that are out there. I'm not here to propose that any one of these are perfect. There's been a lot of discussion about IMT, or the carotid intermedial thickness that's done by ultrasound, and most recently around by Torin and Zetia. Stress testing has been mentioned, the CRP, coronary calcium, and now with 64-slice CT, even more sophisticated CT evaluation. But there may be some use for the Framingham risk as well. This is actually an interesting sort of slide. And I draw your attention to 2 things here. First of all, this is using a Framingham database. And what they did is they went in at a time, 50 years of age, both in men and women, to see what's your cumulative risk over the next 45 years. This went out to 95 years of age. Rather than saying what's your 10-year risk, this looks at your cumulative risk over several decades, which I think is much better when you start to talk to a patient about what their risk is. They don't want to know what it is in the next 10 years. They want to know what it is over the rest of their lifetime. So this is looking at age 50. And the 2 things that are interesting here is down here in this blue line here. So if you're a man and you've gotten to age 50 and you've not had any cardiovascular events, and you have optimal risk factors. In other words, you don't have diabetes, you're not a smoker, your blood pressure is well controlled, et cetera, your chance of having an event is around 5% until age 95. So that's a patient, that would be very comforting, obviously. However, if you have more than 2 or more major risk factors, your chance of having a cardiovascular event in the next 4 decades is almost 70%. So that's a much better way of looking at this, I think, than just the Framingham risk itself. And again, comparable findings with women. There's a step up here at about age 75 or so in women. But again, if you don't have any risk factors at age 50, men or women, your chance of having an event is actually very low. So that's another thing that I think is very important when you start talking to patients about their management. So another way of looking at this, you estimate the 10-year risk factors, 10-year risk with a Framingham risk factor. Obviously, if it's high, they have diabetes, those patients should be aggressively managed. If, on the other hand, it's in that intermediate risk, which is where most patients are, they're in that 10 to 20% risk, some of those patients need to be treated and some don't. A way of looking at that is, again, to take these 10 to 20 and less than 20 and estimate this lifetime risk. What is the lifetime risk of having an event? And the number that's used in this particular is that, just cut out here for a second, is that the lifetime risk is greater than or equal to 40%, those patients should be treated as well. So it gives you another way of looking at this, particularly in these patients who have that low to intermediate risk by Framingham risk scoring. And again, if they're less than 40%, that's where you would go into lifestyle modification, exercise, diet, et cetera. So what about, I'm going to shift gears here a little bit. It's important when you start talking about coronary disease and chest discomfort that you know that you have an idea about what the likelihood is that the discomfort you're talking about really represents coronary disease. Because as you'll see, your ability to risk stratify patients with stress testing and other modalities depends on what the risk is of the patient. So if you're talking about typical discomfort, which is outlined here, versus atypical, obviously if you have atypical discomfort, then your pretest likelihood of disease is lower, and so things like stress testing become more problematic when you start looking at patients. And obviously if a patient has non-cardiac discomfort, they would have obviously a lot of false positives on treadmill testing. This is an interesting slide. What's the likelihood that the chest discomfort or ischemia is from coronary disease? We always talk about these traditional risk factors, and I don't want to minimize that because I think they're very, very important. But this is hierarchical here of the things that are important when you're talking to a patient. What's the nature of the symptom? Do they have a prior history of coronary disease? Are they male or female? And what's their age? The last one on here is the number of traditional risk factors. Important, but it's not the first one on there. We always ask about, do you have diabetes and hypertension and those things, but these other things are more important in picking out the patients who have a high likelihood of having coronary disease and their symptoms being from that. I think it's important when you try to differentiate patients between stable and unstable angina that you understand that has a definition, and this is the definition of unstable angina. It's not someone who, for example, has never had discomfort and all of a sudden has one episode of angina. That's not unstable angina. It's someone who's had potentially angina, and now they've gone from, say, class 1 to class 3 by the Canadian Cardiovascular Society. New onset has a definition. You know, everyone has to develop symptoms at some point if they're going to have coronary disease, so it's going to be new onset at some point. But that's really defined as less than 2 months. It's not the last 6 months they've been having a problem. So the reason this is important, because that changes how, you know, you're not going to admit that patient to the hospital, for example. You might do an outpatient evaluation of someone like that versus someone who has true unstable angina. That typically is an indication for hospitalization and more aggressive management and evaluation. The reason that's also important, as I alluded to earlier, is that if you have true unstable coronary syndrome, that's a different patient population than someone who has chronic coronary disease, because the outcomes are worse, particularly the outcomes in the first 30 to 60 days after presentation. That's a patient that needs to be aggressively managed. As shown here, if you have a high risk, that's the kind of patient that needs to be in the hospital, evaluated, probably undergo cardiac catheterization, versus someone who's at low risk, who could be discharged from the emergency room and have an outpatient evaluation. A little bit about exercise testing. Bill mentioned this a little bit a moment ago. It's best for patients with intermediate risk. If you have someone who comes in who's 65 years old, male, smoker, diabetic, who has chest discomfort when they exercise, that's not GERD. That's probably angina. So you don't need to do a treadmill test really, unless you want to look at prognosis, because from a diagnostic standpoint, you have the diagnosis based on the history. If you want to have a prognosis from the standpoint of that patient, then perhaps treadmill testing would be helpful. The average sensitivity of a regular Bruce protocol treadmill test is about 67%, specificity is about 72%. Most cardiologists don't do a lot of non-imaging stress testing, but that's because we have the tools available where we practice typically. You may or may not have those tools available. So again, just regular Bruce protocol treadmill testing, mostly helpful for intermediate risk patients. The Duke treadmill score is something we use at the U. It's actually pretty straightforward. If you're using a regular treadmill test, it gives you an idea about what the risk is, and here is how they calculate it. It's not so important. It's pretty easy to do, but it gives you a number, and that number has some prognostic capacity. In other words, you're not doing this so much for diagnosis, now you're looking at prognosis. So if they have this high score, which is a negative number in this particular calculation, then that patient's annual mortality approaches 5%, and their 4-year survival is down around 80%, so about a 20% risk of dying in the next 4 years from this particular study. So just the treadmill test itself can give you prognostic information based on how the patient responds to exercise. So it's very helpful. What about the indications for perfusion? The things that are classically determined or classically said to be indications for perfusion, as I said, most cardiologists do imaging on all patients, but if you don't have that available, certainly in patients with left bundle, patients with left ventricular hypertrophy and strain, a WPW, ventricular pacers, digitalis, probably women, and patients who have low pretest likelihood of the disease. And the reason for that is if you have a low chance of the disease, you're going to have a high false positive rate. So if you put a 20-year-old on a treadmill, you're probably going to get a false treadmill. And this happened just the other day, and somebody wants to do a heart catheterization on a 20-year-old who's got some kind of screwy chest discomfort. So, but if you're going to do exercise testing in this patient population that's on this slide, you should consider imaging because that improves your sensitivity and specificity of the test. Again, thallium and sestimibia are the two imaging moieties that are out there. They have about the same sensitivity and specificity. As you can see, the sensitivity is quite high here, about 90% specificity, similar to treadmill testing alone. And the two drugs, the two radiopharmaceuticals are different in their energy levels. We typically use sestimibia in larger patients, women with large breasts, for example, because of the attenuation that occurs. And then obviously PET is considered to be the gold standard. PET's not available in most institutions. We do have it at the University of Washington, and we do use that from time to time as well. You occasionally have patients who have persantin or adenosine stress testing done, and these are sort of the way they're supposed to be used and the contraindications. You have to remember that persantin and adenosine can produce bronchospasm, so in patients who have bronchospastic disease, that's not a good test to do, obviously. Dobutamine is used primarily in patients for echo stress testing. The indications for cardiac catheterization, again, I'm an invasive cardiologist and sort of like to talk about this, but typically this is used in patients who have a high likelihood of mortality, here greater than 3%. So if you have that high Duke score, that -10, where there's a 5% one-year mortality, that's a patient obviously who's high risk and would need an invasive evaluation more than likely. In the intermediate risk patients, you certainly should try to risk stratify those. Those are the patients I mentioned a moment ago that stress testing, either with or without imaging, is important. Occasionally, we have patients who have inadequate response to medical therapy, and occasionally patients which the diagnosis, despite the non-invasive evaluation, remains, again, somewhat unknown, and cardiac catheterization can be used to firm up that diagnosis. I'm just going to hit the class 1 indication here for cardiac catheterization. That's known or possible angina and sudden cardiac death. I mean, that's pretty limited. So again, from the standard approach to using cardiac catheterization for the diagnosis of coronary disease, known or possible angina and sudden cardiac death. Again, these other things are outlined, as I mentioned a moment ago. But if you have acute coronary syndrome, the reason I mentioned a moment ago, the difference between chronic coronary disease and acute coronary disease is the risk is different. So if you have someone with acute coronary syndrome, there's a whole lot longer list here of indications, class 1 indications for cardiac catheterization, including recurrent angina, obviously, on medical therapy, an elevated troponin at the time of presentation, ST segment depression, high-risk non-invasive studies, a low ejection fraction is an indication for cardiac catheterization, here less than 40%, recurrent ventricular tachycardia, and anyone who's had any kind of revascularization procedure in the prior 6 months, and in the case of bypass surgery, longer. So those are the class 1 indications for an invasive strategy. Now, more recently, the American College of Cardiology has come out with a 2B indication. In other words, it gives you the option of a different approach. In patients who come in, for example, who have low troponins, the troponins are positive, but they're not that high, that patient could, if they're stabilized, undergo a non-invasive evaluation if you so desire, but that's a class 2B indication, not class 1. But they have liberalized that a little bit. Okay, turning now to secondary prevention. And I've alluded to this a little bit, and I want to make sure you understand what the terminology is here. These are the ACCHA guideline classifications. You've heard these mentioned several times today. Class 1 is that is useful and effective, usually proven by multiple randomized clinical trials. Class 2A is less evidence, but the data would suggest efficacy. Class 2B is less well established, and Class 3 is something you should not be doing. So the way I look at these, Class 1, we ought to be doing that in everybody. Class 3, we should be doing that in no one. The Class 2 gives you a little fuzziness there for clinical practice, but I'm going to concentrate primarily on the Class 1 and Class 3 indications. So what about the pharmacologic therapy of chronic stable angina we're talking about now? The Class 1 indications are all very familiar, and I'll go over these very briefly. Aspirin, now it's got an asterisk beside it because if the patient is allergic to aspirin, then clopidogrel or Plavix could be used in that patient population. That's a level 2 indication, but nonetheless gives you an option in a patient who is truly allergic to aspirin. A beta blocker, an ACE inhibitor, particularly in patients with diabetes and LV systolic dysfunction, that is the Class 1 indication. An LDL lowering therapy, nitroglycerin is needed. And calcium antagonists or nitrates, when you've already got a patient on beta blockers or they can't take a beta blocker and they continue to have symptoms. So there is a role for those drugs as well. Again, but the beta blocker, ACE inhibitor, and statin with aspirin are really the cornerstones of therapy. This looks at the aspirin recommendations here. Class 1, as I mentioned a moment ago, the question came up about how much aspirin, and I'll show you a brief slide of that. Somewhere between 75 milligrams, as far as I know, that's not available in the United States, but certainly 81 milligrams to 162 milligrams, or 1 to 2 baby aspirin a day, unless contraindicated. Patients undergoing surgery, slightly different, higher dose. And this post-PCI piece, I'm going to cover that a little more in detail in just a moment. But because of stenting, there's a higher dose of aspirin given. If it's a bare metal stent, it's about a month's worth. If it's a drug-eluting stent, about 3 to 6 months, depending on the device place. And I'll touch on that a little bit more in just a moment. Those are all class indications for aspirin. This is the data that supports that. Again, you're all very familiar with this. There's no doubt that aspirin has become more or less the cornerstone of the treatment of coronary artery disease and acute ischemic syndromes here, both cardiac and non-cardiac vascular disease, also for stroke as well. Because again, this is secondary prevention. We're not talking about primary prevention right now. Aspirin, what about the dose of efficacy? The reason this top is red is that this is higher dose aspirin, and what you get with higher dose aspirin is more bleeding. It is effective, but you get a complication of more hemorrhagic events. So if you look here, somewhere in the 75 to 150 milligram range, again, this is antiplatelet better versus antiplatelet worse. These trials overall are all very significant, but probably between, as I mentioned, 81 and 162 milligrams in the average patient with chronic coronary disease as secondary prevention is the dose of choice. This is the recommendation for clopidogrel. It's a class 1 indication for acute coronary syndrome. So if someone comes in the hospital, they'll get aspirin and clopidogrel at this point. On average, the patient should receive the combination drug for approximately 9 months. That's based on a prior study. If they've gotten PCI, then it can be up to 12 months, and I'll go into that in more detail in a moment. And if you look down here, you've got this breakdown, which is a little bit confusing, but if you have a bare metal stent placed, then it's about a month. If it's a drug-eluting stent, there are 2 kinds of drug-eluting stents currently on the market. Actually, that's not true. There's a third one that just got approved here recently, and a fourth one about to be approved probably this summer. Again, depending on the different drug-eluting stent, different amounts of time on clopidogrel, and I'll hopefully bring this to some conclusion about how long they should be on it in just a minute, but that's the current recommendation. This is based on, as far as unstable angina, is based on the CURE trial, again showing aspirin plus clopidogrel was superior to aspirin alone. This is the reason that when patients come in with acute coronary syndrome, they frequently now go out on both aspirin and clopidogrel, and not just aspirin alone. This is one of the problems, as I alluded to earlier. We've known about this for several years. This is a study that was published in 2005 in JAMA, and this looks at this whole issue about subacute thrombosis of stents. And I think it's important to understand that when patients come, you probably won't see these people. They're not likely to walk in your office because this is an acute event. This is not unstable angina. This is an acute STEMI is what happens. These things clot, and when they clot off completely. So they don't present with sort of vague kind of chest discomfort. It's a sort of a yes-no kind of thing. They're either having it or not. So it's not subtle. And not only is it not subtle, but premature discontinuation of the dual antiplatelet therapy in patients with drug-eluting stents is associated with significant mortality. In this particular trial here, the case fatality rate was almost 50%. So this is a serious problem. It doesn't happen very frequently. Again, in this study, about 1.3% of the time. So around 1% of the time, we have acute thrombosis with these drug-eluting stents. But when it happens, it's a big problem because the mortality rates are quite high. So this prompted the American Heart Association and all these other initials up here to come out with a scientific advisory statement that was published last year in Circulation. And what this really says, and this is what you are likely to see, you see the patient who comes in has got to have gallbladder surgery or something else done and their own dual antiplatelet therapy because they've got a drug-eluting stent there. And you need to know how to have that conversation with the patient about what should be done. So if they're having an invasive or surgical procedure, and they've had one of these stents placed, we tell patients this. You need to talk to the cardiologist who put it in. Somebody that knows what was put in and what the likelihood of thrombosis is. So you need to have a conversation with the cardiologist involved. If it's an elective procedure, it should be delayed for 12 months. So if they've got to have their knee fixed, don't put a drug-eluting stent in. You need to let the cardiologist know that so that they don't put that type of stent in. But if they have a drug-eluting stent in and it's an elective procedure, you should delay that for 12 months before you stop the dual antiplatelet therapy. If it's not an elective procedure, then that you can discontinue it, and we'd certainly not like to do that if at all necessary, if we don't have to do that. But if we do, they should remain on aspirin if all possible, and the dual antiplatelet therapy should be started immediately as soon as possible after the procedure is performed. So again, urgent procedures, stop the Plavix, continue the aspirin. Elective procedures, 12 months of Plavix. What about lipid management? Again, as I alluded to earlier, class 1 indication, LDL less than 100. So when you put someone on atorvastatin or simvastatin or whatever, that's the goal, less than 100. A 2A indication is less than 70. in patients high risk, younger patients, diabetic patients, people with multiple risk factors, multivessel coronary disease, et cetera. Again, more aggressive management of LDL, I think, is in order, and the target being less than 70. These are the ATP3 goals, and not to get into too much detail here, but you have this high-risk group. They've divided this actually into 4 categories now, but the high-risk group, this is where they start talking about the optimal goal, less than 70, as I alluded to earlier. The moderate high risk, this less than 100 being the goal. The 130 is also there. And you have this low-risk group of patients at less than 160. So, you know, I take simvastatin myself. My LDL was 165. I don't think that's normal, okay? Even though the guidelines would say that if you had an LDL of 155 and you don't have any risk factors, which I don't, you didn't have to do anything about that. But I'll be honest with you, I think that's epidemiology, and when you start dealing with an individual patient, I just don't think an LDL less than 160, over 160 is really reasonable, and certainly if it's close to 160, I think it should be less than that. That doesn't mean you necessarily need to be on a statin. Therapeutic lifestyle changes, dietary, and all the things that we're going to talk about here in a moment are very important. But that's in the U.S. and European population is considered reasonable. But I don't think that's really a good LDL for anyone. If you look at the data behind the use of statins, there are several. This is the heart protection study. This is in about 20,000 patients with known disease. Again, we're talking about secondary prevention here. If you look at all patients, no doubt, statins have an impact. So if you look at these slides, it doesn't reduce if you get your LDL down less than 70, you still have a risk of an event. You don't completely get rid of the risk, but you significantly decrease it. So I think it's unfair to say that the LDL hypothesis is not important. I think it's equally unfair to say that it's the whole story. It's not. It does have an impact, though. This is looking at the only comparative trial out there between 2 drugs, and this sort of, again, leads one to believe that LDL is important. And what this trial really showed was that the lower your LDL was, again, using atorvastatin versus pravastatin, and this didn't come out red, the bottom line is atorvastatin, you did better. So the lower, and the average LDL in the atorvastatin group was less than 70, and the average LDL in the pravastatin group was around 90. So the lower the LDL, the better these patients did. These were fairly hard endpoints. These were recurrent cardiac events or cardiac death. And this is sort of the line that you get from this, and patients always come in and say, well, you know, what does my LDL need to be, and how low is too low? We don't know how low is too low, but what this line looks like is pretty straight. So the lower your LDL, if you look at events there on the event axis, the lower your LDL, the better off you do. These are multiple trials here showing that. So LDL is important. The lower, the better. It is not the entire story, however. The ACC, AHA have also recommended, again, as a class 2 indication, the use of stanol esters in particular. That can lower your LDL about 10 or 15%, as can soluble fiber and soy protein. So those are important parts of the diet as well, although they're not class 1 indications at this point. They're class 2. This comes up every once in a while. Can you use niacin in diabetic patients? As most of you know, the use of niacin increases the glucose level. So your diabetics will have more difficulty with control. But this study would suggest that although that does happen and you have to increase the dose of the medications, there are no untoward events. They're no more likely to develop toxicity to niacin than anyone else. But you do have to be aware of the fact that their diabetes control may become more problematic, and you may have to increase the medications to treat that. But it can be used safely. What about omega-3 fatty acids? This commonly comes up in my practice at least. And this again is these are class 2 indications, but for patients with coronary disease as secondary prevention, there are a couple of trials out there suggesting that omega-3 fatty acids are beneficial. In high dose, they're also beneficial in lowering triglyceride levels as well. So in patients with poorly controlled triglyceride levels, high dose, in the 2 to 4 grams of omega-3 fatty acids a day can sometimes be helpful as well. Again, not class 1, these are class 2 indications. Nonetheless, you'll see people frequently taking this. What about beta blockers in secondary prevention? Class 1 in patients with following a myocardial infarction or acute coronary syndromes, and all patients with low left ventricular ejection fraction. As Dr. Levy pointed out earlier, all those patients should be on a beta blocker as class 1 indication. Some of the data here, again, you're very familiar with this. These are meta-analyses, 50,000 patients in this particular overall meta-analysis showing a benefit to beta blockade in these patients. Left ventricular dysfunction, this is the carvedilol trial. Capricorn, I think he may have mentioned this trial earlier as well, showing that carvedilol versus placebo was beneficial in reducing the events in follow-up here out to 2 years. In a very significant fashion, a relative risk reduction, about a 30% improvement in outcome with carvedilol versus placebo. I'm not here to push carvedilol. I mean, as he mentioned, metoprolol is another good option in these patients, but one of those two drugs has been shown to be beneficial. What about ACE inhibitor recommendations? Again, the class 1 indication here is for patients who have diabetes, chronic kidney disease, and or a low ejection fraction. Here defined as less than 40%. It's not everybody at this point. Optionally though, and frequently you'll see patients who don't meet these criteria that are being treated with ACE inhibitors. And that's a class 2 indication. Again, I'll just go through this for the sake of time. The receptor blocker question comes up from time to time. About 10% of people cannot take an ACE inhibitor, usually because of chronic cough. Another thing to remember, a patient comes in to see you, had a myocardial infarction or put on an ACE inhibitor a month ago and they got this persistent chronic cough. It's probably not postnasal drip. I mean, it's probably from the ACE inhibitor. So think about that when you see patients because they're usually fairly miserable from it. If you stop it, it'll go away. If you stop it, you should consider using an angiotensin receptor blocker. Again, in patients who can't tolerate an ACE inhibitor, it's a class 1 indication. It's a class 2 indication in combination with an ACE inhibitor for heart failure. But again, the ones to remember here, class 1 for patients who meet the same criteria as the ACE inhibitor I mentioned a moment ago. What about aldosterone antagonism? Very similar. This is for patients who have low ejection fraction, diabetes, or heart failure. The addition of an aldosterone antagonist is a class 1 indication as well. Again, you've got to watch people who have elevated renal, elevated creatinine, elevated potassium, as Dr. Levy mentioned a moment ago. What about physical activity? This is a fairly interesting slide, and what it really shows is that the very active patients do pretty well where they have coronary disease or are considered normal. If you're not very active, you do just about as poorly, whether you have coronary disease or not. This is the relative risk of death on this axis here, and so with or without coronary disease, if you're not very active, you're not going to do as well as someone who is active. So exercise is very important, and again has a class 1 indication, as does weight reduction here as well. And I won't get into the BMI question here, but the easiest way to take care of this, and now I don't have all my prevention colleagues here in the room, they won't get on to me about this hip to waist ratio and things, but if you just ask what size is your belt, if you're a female, it should be less than 35 inches. If you're a male, it should be less than 40. And if you calculate the BMI, if you're above that, then you're considered obese. And that's a really easy way to find out where a patient meets the definition of obesity or not. And again, that's very important. Activity is very important here. The goal, the minimum goal here is 30 to 60 minutes, at least most days of the week, which would be defined as 5 days a week, and optimal is 30 to 60 minutes, 7 days a week. And in Seattle, we're sort of blessed with people who take this to the extreme sometimes, and they're doing a lot more exercise than this. In other parts of the country, it's a little more problematic. But again, physical activity being very important, as I alluded to earlier, it has an impact on outcome, even if you don't have coronary disease. If you're physically inactive, you just don't do as well. Cigarette smoking, again, a class 1 indication here. It's important to ask the patient. Patients want to please us. If you don't ask if you're still smoking, they won't tell you probably. They won't volunteer, I'm still smoking a pack of cigarettes a day. So what they recommend here is you ask every time that you see a patient whether they're smoking or not. And I had a guy slip by me the other day, about a 40-year-old guy who's got multivessel coronary disease, had multiple stents, and he's still smoking cigarettes. And I had forgotten to ask him, and on one follow-up, I noticed a pack of cigarettes in his pocket. So you got to ask, and you've got to be very direct about it. You can't fiddle around here and say, well, you ought to stop that. You got to tell them to stop it. They'll listen to you if you tell them, but you have to ask every time, and you have to be very firm about the importance of stopping cigarette smoking. What about the class 3 interventions? I said a moment ago I was going to concentrate mostly on class 1 and class 3. So these are things you shouldn't be doing. And there are a lot of things on this list that you'll see patients doing. The postmenopausal therapy has been pretty well publicized, that that's no longer really indicated unless you just have absolutely no choice. The patient should be taken off of those drugs, particularly patients who have cardiovascular disease. Again, this is mostly about secondary prevention. The antioxidant supplements, very popular in Seattle and the Pacific Northwest, but there's no indication that vitamin E, C, beta-carotenes have any impact on outcome in patients who have known coronary disease. Folic acid, same thing. These were great ideas, but there's, again, no evidence that these drugs are beneficial, although you'll see a lot of people still taking those drugs. Some misconceptions here, and I didn't get into a lot of detail here. I think the other thing important about treadmill testing is a negative treadmill does not exclude coronary disease. And that's very important when the patient walks into the emergency room and says, I had my executive physical last week, and you're telling me I'm having a heart attack today? How could that possibly be true? That's because treadmill testing only picks up obstructive coronary disease. You've got to have a significant lesion there to stop blood flow during exercise before it shows up either as ST segment depression or a positive perfusion scan. So you can still have that vulnerable plaque, you can still have 40%, 50% lesion, not going to show up on a treadmill test. That's the patient population that sometimes shows up later with an event. That's the reason these tests are not perfect. So you got to remember that. The patient could still have coronary disease even with a negative treadmill. The severity of coronary stenosis predicts the infarct artery. That's not true either. Used to be we thought, well, if you got an 80% stenosis in your LAD, that's when it's going to close later. That's not really true. It's the 50 to 70% stenosis that's more likely to rupture than the more mature 80% stenosis, let's say, because of that vulnerability of the plaque. It's hard to predict which one of these is going to close. I also would say that the misconception is that stable angina is bad. This happened yesterday at the university. A patient's got known coronary disease, was walking on the Burke-Gimlin Trail and had one episode of angina, got popped in the hospital, getting a cath. I think that patient should have had more medical therapy, or you should say, well, let me know if it gets worse or if you start having it at rest or it wakes you up at night. So angina by itself is not necessarily bad. Now, patients don't like to have it and they want it eradicated. But on the other hand, if it's just angina and it never causes an acute event, then that's not a bad problem, provided the patient is reasonably functional. And then as I alluded to earlier, everyone with hypercholesterolemia who should be treated is treated. That's not the case. There are a lot of patients who are either treated inadequately or not treated at all. And the treatment of coronary disease is unimodal. What I mean by this is you get a stent or bypass surgery or you don't get anything. And I'm an invasive cardiologist, and I don't believe that. I think that, as I said earlier, medical therapy is a very important part of this. And what I explain to patients, if I do a stent, we're taking care of the acute problem today, but you're going to have to be on medical therapy the rest of your life for this disease, because that stent and that bypass operation does not change the natural history of the disease. The medical treatment does change the natural history of the disease. So some final comments here, just to kind of touch on a couple of things that have been in the lay press. The OAK trial, for those of you not familiar with this is a trial where they took patients 3 to 28 days post-infarction. In other words, patients who didn't get picked up, essentially, with their acute infarction, out to about a month, who had totally occluded vessels, and they wanted to know whether if you opened up that vessel, really with no symptoms, whether that patient would do better or just medical therapy would do equally. And what this trial really showed is it didn't make any difference. Now, if you think about it, why would it? If you have someone who's come in and had a myocardial infarction, they've completed their infarction, their vessel is closed, they didn't get thrombolytics or PCI to open the vessel up acutely, and you do it within that first month after that for really no reason. In other words, no recurrent symptoms, no significant angina, no clinical thing driving this other than the fact the vessel's closed. What this showed is that you shouldn't be opening those vessels up. I think that's a fair statement. It doesn't mean that people who have chronic total occlusion shouldn't have them opened up, but if you fall into this very specific, limited trial, you shouldn't have those opened. But if you have significant ischemia on a treadmill test, you have recurrent angina despite medical therapy, and you've got a chronic total occlusion, probably should be opened up. That's not what this trial is really talking about. Although in the lay press, that's what they tried to say, is we shouldn't open any of these. That's not true. There are still patients who have totally occluded vessels where opening that vessel up is beneficial from the standpoint of symptoms. So the other one that's out there, the COURAGE trial. And what this trial looked at was if you took two groups of patients and you put them on maximal medical therapy, in other words, ACE inhibitors, beta blockers, nitrates, statins, everything, they were both on maximal medical therapy, and you randomized half of them to percutaneous intervention and the other half to just medical therapy, would you live longer? And that's what this shows. And the answer to that is you don't. That doesn't mean that there aren't patients who would benefit from that. And subsequent study here, if you look at the treadmill data on this patient population, the patients who got intervention took fewer medications and had fewer symptoms and had less ischemia on treadmill testing. So it depends on what your endpoint is. If you're trying to prove mortality, I think it's fair to say that in STEMI and in STEMI, that percutaneous intervention has an impact on mortality and outcome. If you're looking at chronic coronary disease, it probably doesn't. And it stands to reason that it wouldn't, for the thing I said just a moment ago, is that a stent does not cure the disease. It treats symptoms. That's not necessarily bad. If symptoms are important to the patient, not necessarily bad that they're on fewer medicines and have fewer symptoms and can exercise farther. So, and again, this has gotten a lot of press, but I think a lot of press not really completely deserved. Okay. Well, thank you very much for your attention.